Hello, everyone. I'm Mike Seidman. I'm a cardiovascular pathologist practicing at UHN in Toronto. Dr. Cusimano asked me today to talk about a pathologist's view on the tumor biopsies and specifically what's enough, what sort of adequacy considerations are there. Since when taking a biopsy, that's frequently a concern is that if you miss, you have to go in and do another procedure. So to give you an idea of the range of what we might see, the image on the left, the white bar is a 1 centimeter size reference. This is a 9 centimeter cardiac fibroma resection that was done at one of my previous institutions. In contrast, on the right, again, that is a 1 centimeter scale bar. This is a small cardiac biopsy. We see significantly more of what's on the right, so we've had to develop tools to best adapt to that. I just wanted to say I have no disclosures or conflicts of interest. And to the best of my ability, I've tried to cite sources on images. If I missed one, I apologize in advance. And a lot of the images, especially when not cited, are my own. So what I'm going to attempt to do is give you some of the principles of pathology evaluation of biopsies, particularly of cardiovascular masses, from the point of view of a pathologist. And what the important considerations I view in obtaining adequate biopsies, and then giving some tips in new ways that we might be able to start approaching tumor biopsy and sampling that might even further improve our experience. So it's important first to state why we're even doing the pathology, and what I view my job to be and my colleagues' jobs to be is that you need to be able to treat the patients when you're in the clinic, be that surgically, medically, et cetera, and we need to provide you enough information to do that. And I specifically state it that way in that we're never going to be able to tell you literally everything, but we can almost always tell you enough to take the next step forward. And our goal is to not tell you simply, I don't know, although that will inevitably happen sometimes. So diagnosis is really what drives most of the workup. Frequently, we're asked to obviously evaluate margins of resection to determine, basically if tumor is left, as many of you know. And in some cases, we are seeing post-treatment resections, and the question is how well tumor has responded to previous treatment, which would then presumably inform future treatment. Now, all of this is dependent on having enough material to answer the question. So I will say diagnosis, which does drive most of the adequacy question, is balanced against a few different things. So the as soon as possible concept, the speed, is perhaps a more complex concept than often conceived, in that there's what the surgeon needs to know instantaneously, or the proceduralist needs to know instantaneously. There's what the treatment physicians need to know in the next day or two, and then there's what information needs to ultimately be known in toto. Communication is fairly easy these days. Email provides a written record. Preliminary reports can usually be issued. So the speed of a report can vary from minutes to weeks or months, depending on how much information is gathered. And effectively, these are balancing accuracy and precision. What I can tell you on day one will not be very precise and is more prone to error. On day two, we can be pretty accurate, but not precise. And over time, we get progressively more precise and progressively more accurate, although preliminarily, we can at least tell you things like the class of tumor. So I'm going to open with a case. I have 3 vignettes scattered throughout the talk. Case 1 I've named a joint effort. This is a 36-year-old female with new onset chest pain and shortness of breath, no significant past medical history. And in workup of her shortness of breath, imaging identified a 7 centimeter mediastinal mass. A biopsy was taken and the image is shown. So it was done by percutaneous needle biopsy, and the H&E histologic section the next day came back as spindle cell lesion. What I knew was what you see in front of you, in that they were elongated, so-called cigar-shaped cells with big nuclei. They looked pretty unusual, and I was pretty sure this was some sort of cancer, but I was cautious. I did some stains, so this would now be the 2nd day post-op, and I could confirm that it was a sarcoma, but that was about all I knew, and we didn't have the resources to do much more at UHN. So after we ran out of stains, we sent it across the street to our colleagues at Mount Sinai Hospital, who have a specialized sarcoma group. And I will follow up later with what happened next. So in this context, it's important to talk about what types of masses we see. The most common mass in the heart that we actually see from a chamber is by far thrombus. And in terms of neoplasms, probably these days we're seeing myxoma more than metastasis, although in the past, metastasis was probably more common. One of the things we do see a lot of is scar, damage from other sources. Thrombus itself can be reactive or primary. And myxoma and a couple other lesions are the benign lesions we do see. And these are sort of the first things we think about, although frequently with the modern tools, something comes to us with a higher degree of suspicion if it's not one of these things. And this is actually the gross picture of a myxoma. The small little pieces show how bloody these things are and how much they can look like thrombus. And in fact, the cut section even shows hemorrhagic change in the center of the tumor, the arrow pointing out the little stalk attached to the myocardium. So then, of course, there's the malignant lesions, which is perhaps the focus today. And more common than anything else is metastasis, although they are less commonly biopsied, although frequently treated with surgery. The most common is certainly carcinoma, the lung and breast being adjacent, and the liver and kidney by virtue of ascending the IVC are lesions that are commonly seen. I have certainly heard anecdotes of others. Those happen to be the only 4 I personally have encountered so far. Melanoma is actually not uncommon. There are several really marked cases of melanoma metastasizing to the heart. And lymphoma involvement of the heart is not uncommon, at least as cardiac tumors go. The primary lesions, by far the most common, is sarcomas. It is a soft tissue organ. You would expect it to be soft tissue tumors. Mesothelioma of the pericardium also does exist, and lymphomas that originate in the heart and are primarily diagnosed there certainly also exist. So this is an example of melanoma metastasizing to the heart and replacing a majority of the myocardium. Fortunately, this one was pigmented, so it made for a nice picture, but unfortunately not a good story for the patient. And the bottom is a picture of a pericardial mesothelioma. These do come up. I have seen one that was an accidental finding at Cabbage. And sometimes these are very straightforward and sometimes less so. I'm going to move on to my second case vignette, which I called What's the Bloody Diagnosis? This 50-year-old had new onset shortness of breath. Again, no significant past medical history, and a 4-centimeter epicardial mass. The pericardial effusion that resulted was aspirated and sent for cytology. And that is seen off to the right in what's called a Giemsa stain, a common cytologic stain that has some similarity to H&E, but with better cytomorphologic detail. And it was almost immediately identified that there were numerous small atypical blue cells, which is a category, so to speak, of neoplasm, frequently malignant, that includes a bunch of different types of lesions, and that has a fairly well-defined workup process. And numerous additional material was available, and the process was started from there to proceed. And I will give you more follow-up later in the talk. So this raises the question of some of the tools we use. Obviously, for surgical specimens, the gross evaluation is key, particularly on cardiac specimens. Assessing orientation, what parts are included, where tumor extends can be very valuable for future planning. Although on biopsies, the gross is usually not all that useful. We can comment on the color, which sometimes is helpful, sometimes not, and the size. Frozen section is often used for surgical specimens. I do want to point out that it has a very high error rate relative to permanent sections, to formalin fixed, paraffin embedded, but it is very fast. So in the middle is an example of frozen section, while off to the right is an example of permanent section of the same lesion. Off to the left is cytology taken at the exact same time as that frozen section, which actually gave better picture of the cells, where the big cells are compared to smaller lymphocytes and can be more easily identified as atypical. In the middle, I have to admit, I would be mildly confused as to what I was looking at, although fortunately there are some smaller, more normal cells towards the top. And on the right, there is no question that that is a neoplasm. In fact, this was a Ewing sarcoma. So continuing along the tools we use, The workhorse continues to be paraffin sections. Of note, the sections we take are typically 4 microns thick, and a typical slide from a biopsy will have 3 cuts of the tissue on there to make sure that we get a representation of the tissue that doesn't fragment, doesn't fall off the slide during processing, et cetera. Now, it will become relevant that an 18-gauge needle inner diameter is less than a centimeter, so we only have so much tissue to work with. Some other types of biopsies, this is a different consideration, but the needle biopsies are common, and I thought it would be useful to use that as an analogy. So when we get to histology, we always need H&E stain. It is what almost everything else is based on. It is the workhorse of pathology histomorphology. We do order a number of other stains, and in fact, in this cardiac fibroma shown, the key finding was actually on trichrome and Movat pentachromes, much less so on the special stains, since cardiac fibroma is kind of stained for nothing. Each stain that we perform takes about 20 microns, and we usually perform more than one H&E to make sure that we represent different depths of the specimen. So you can add up fairly quickly to a sizable portion of the core. Immunohistochemistry has really become one of the workhorses of tumor phenotyping, and it'll typically take between 5 and 20 stains, plus or minus, to identify the type of lesion in a particular case. Each of those takes another 20 microns. And in the modern day, it's relevant that molecular diagnosis, which really has become the gold standard and drives a considerable amount of care right now, requires an additional 1 to 2 millimeters of tissue depth for optimal testing, which obviously on a needle core dramatically limits the amount of material available and raises the question as to how much we can get away with. And in modern techniques, less DNA is frequently usable, but it does require that a significant fraction of that core actually be tumor. Case vignette 3, what am I? A 45-year-old male who was just generally unwell. There was a 2-centimeter intracavitary RV mass and had a massive significant history of alcohol abuse. On the left is the H&E histologic stain, and on the right is a cytokeratin immunohistochemistry. These are on endomyocardial biopsy performed by catheter. The H&E was available approximately 24 hours after the procedure and favored carcinoma based on its particular findings and morphology. It took several more days to get the immunohistochemistry, at which time keratin confirms that it is in fact a carcinoma. However, additional stains were still required to tell more than that. So some of the limitations we face that perhaps are the most important in considering the nature of the biopsy to be performed is one of the biggest limitations is, did the tumor get sampled? And this is limited both by the things that are listed below this, as well as the fact that identifying the tumor itself can obviously be challenging without direct visualization. Modern imaging is obviously infinitely superior to in the past, but it's still possible to catch a cystic portion of it, to miss the tumor cells and capture the material around it, et cetera. So in particular, tumor necrosis and surrounding tissue necrosis can appear mass-like, but is not useful at all for evaluation. Desmoplastic fibrosis surrounding a tumor, again, is not diagnostic. It'll be the reactive process and not actually sample the tumor itself. And thrombus, particularly in the context of cardiovascular lesions, is a major limitation. One additional note, and this is relevant going back to the size of the samples, if we have to go back on a subsequent day and cut more slides, it is not uncommon to lose another 100 to 200 microns of tissue due to what's called refacing. So the block will not be aligned the same way on the microtome. So the cutting will actually require a couple cuts just to get into the block again, at which point we are losing a little bit more tissue. So the more material we have up front, the easier it is to diagnose. Whereas in lesions such as the one pictured, it was very challenging, and more or less we ran out of material before we could do very much. So this is a sarcoma resection. This individual had a remote history of childhood osteosarcoma, and the majority of the lesion when sampled was thrombus and necrosis. There was a little bit of viable tumor, I do not know the status of the molecular testing on this case. It's relatively recent, but it is presumed that this is metastasis from osteosarcoma, which would actually have no specific findings on molecular testing. The major problem when I reviewed this case was that there was so little tumor present that there really was no value in me performing additional stains, and we had to wait for the additional workup. So this raises the question of what specimens might come to us and which are, in air quotes, better. So needle cores certainly are the traditional finding in most tumors, less invasive than many other options. And increasingly, as surgeries go in, even for things such as placing people on mechanical circulation, we're seeing a fair number of intraoperative true cut biopsies. It's important to note that we have to layer these longitudinally, and as a result, the width from the perspective of the needle is actually what determines the amount of depth we can sample from. So a 1 centimeter long core gives us a lot of tissue to look at per slide, but only generates so many slides. In contrast, a transcatheter endomyocardial biopsy, as pictured on the right, takes a chunk of tissue out that's usually 1 to 2, sometimes 3 millimeters across, frequently several chunks. As a result, no matter how it gets embedded, we see relatively the same amount of material, and we get more slides of depth out of it and more material for future testing. I will say I'm a pathologist. The more tissue you give me, the better. So open biopsy, i.e. excisional biopsy or resection, are obviously my preference for reviewing things. It is much less likely to face limitations, but I am not oblivious to the patient impact, of course, and want to do everything in my power to make biopsies work. It's just when you ask your pathologist how much is enough, the reflex is the more the better. So I'm going to come back to my cases. Case 1, this was the 36-year-old female, 7 centimeter mediastinal mass, was diagnosed as a spindle cell sarcoma without type. Even the expert agreed it was spindle cell sarcoma, threw a bunch more stains at it, but really couldn't conclude. There wasn't a ton of tissue left, but it was ultimately sent for molecular via a fancy new assay called the TrueSight fusion panel, which identifies a set of common rearrangements, cytogenetic rearrangements, found in certain types of tumors. And this particular one was found to have the diagnostic fusion protein for synovial sarcoma. So although it didn't have the histologic findings or the staining findings that were individually diagnostic, a very specific diagnosis was reached on molecular. However, that was pretty much all the tissue we had. So had any further studies been necessary, or in the future, as things are developed, we really have no more material on such a case. That said, it is likely at this point enough guidance has been given for chemotherapy, radiation, surgery, etc. Case 2, this was the pericardial effusion that was diagnosed as small atypical blue cells, but with tons of material. So by post-op day 1, this had been sent for a rather extensive hematologic workup and numerous stains. So they make what's called a cell block, which I'll talk about in a few minutes. And CD45 stain, which is a pan-leukocyte marker, was positive. Additional 30 stains and the flow cytometry within, I think it was 3 or 4 days, resulted in a definitive diagnosis of B lymphoblastic lymphoma, and significant material was left to further do molecular testing. This particular case was highly cellular. The effusion had lots of tumor in it, but it is an interesting contrast given the nature of how cytology is performed. And case 3, what am I? This is the 45-year-old with the intracavitary mass and significant alcohol abuse, and all we got to was carcinoma. However, given the clinical and histologic suspicion, I continued working up for hepatocellular carcinoma. And the traditional stain that we performed, called HepPAR, was negative, at which point I was a little let down. Of note, nothing else was positive, so I ended up with carcinoma not otherwise specified. But this is a relatively well-differentiated lesion. I could still see structure in it, and something didn't jive. So I talked to some of my colleagues, and there's a fancy new stain called Glypican 3. When we stained that, the exact same piece of tissue was positive, confirming a diagnosis of hepatocellular carcinoma, just the immunophenotype had changed during the course of metastasis, processing, etc. Of note, though, that is the exact same field of tissue And you'll notice on the right, there is considerably less material than on the left. So as that gets deeper and deeper, we will get progressively less and less tissue, which is relevant for future ancillary studies such as molecular. So this does overlap with some of the questions around intraoperative consultation, because that will also affect adequacy. I am the first to tell you that if you're going to do something different in surgery as a result of a frozen section, it is completely indicated. However, I'm also the first to tell you that if it won't change anything intraoperatively, it might not be the best route. The quality of a frozen section, as we've shown before on the top right, is the same image you saw, is significantly lower quality than the permanent section from the same lesion seen on the bottom right. So you could be looking at a difference of as little as 18 to 24 hours, depending on the facility availability, with a considerable increase in the quality of the information you will receive. As a result, you have to balance these two things against each other. If it won't change what you're doing that day, it's probably worth considering an alternate technique such as a rush biopsy. The other thing to consider is cytology. So on the bottom right is the cytology image from the previous case. And this is just one of several preparations they made in this particular instance. And they were much more comfortable diagnosing this as a malignant lesion than was the individual performing the frozen section. So this is very, very valuable in considering, because we can actually generate cytologic preparations even from the material taken intraoperatively from a surgical approach. So I thought I should talk about cytology because it's not very common in heart or in soft tissue tumors. So it's very common in carcinomas. The lung folks use this rather frequently through endobronchial ultrasound guided fine needle aspirates. It's used in a lot of hematologic malignancies. And the question really comes up is, could it be useful in cardiovascular tumors? So for fluids and effusions, as I showed you in case 2 previously, it's very effective if the material is cellular. So the material is basically pelleted onto a slide using the funnels that you see in the centrifuge on the top. An individual funnel is shown below. About 100 microliters of the cell suspension is loaded into that funnel, and the centrifuge then effectively spins it onto the slide, where the small foam pad you see on the right absorbs the fluid while the cells stick to the charged slide. This is excellent for providing histologic, cytomorphologic evaluation of the lesion, and can be done in a very rapid time frame, sometimes same day. That same material, the remaining fluid, can then be pelleted and combined into what effectively becomes a piece of tissue, although not oriented the same way as in vivo, which can then be converted to an FFPE block and evaluated through the same traditional histologic methods that are used otherwise. Again, this is really best performed the more cellular lesions. A paucicellular lesion will be very hard to work up that way. Fine needle aspiration has become one of the workhorses of cytology. This is using simply a smaller gauge needle than would typically be used for a needle core, and several rapid passes of a cutting needle captures a little tiny bit of tissue in the needle that is aspirated back into the syringe and placed onto a glass slide by pushing it back out. This material is effectively isolated microscopic clumps of the tumor, but provides for a near instantaneous, in the span of 5 minutes, evaluation, in that the 4 vials you see in front of you, it's a few seconds to a minute in each of those 3 initial vials. The water is largely to wash off the extra. Copper slipping takes mere second. And with a microscope provided on site, it is possible to tell you if there's lesion there, which is perhaps the most important thing. You can then guide along the same track depending on the sheath you're using for a needle core, hypothetically. A lot of places use this in other contexts. Plus, you can do it again rapidly, and in some rare cases, you can get a diagnosis. The fine needle aspirate is also potentially usable for downstream diagnoses via a variety of techniques, although frequently the techniques mentioned on the previous slide would warrant more material. And then there's the, you sent us surgical or biopsy tissue, what can we do to help you in terms of cytology? And again, this is not commonly utilized. I've only started asking the question in the past few months, and I am not directly engaged in the process of generating these slides as of yet. Other centers have had significant success with sarcomas. I don't know anyone specifically doing this in cardiovascular. But what can be done is the tiny piece of tissue you send us, such as the needle core seen on the images there, can be dragged across a slide or tapped onto a slide several different times to generate either a touch prep or a smear, where enough cells are taken off to provide for a rapid assessment similar to a fine needle aspirate. It is also possible with a larger section to run a glass slide across the lesion, such as a several centimeter tumor, like the one shown on the first slide, and spread those cells across a glass slide to accomplish roughly the same evaluation. This process allows for a traditional needle core or catheter-driven biopsy to be evaluated for adequacy in the context of being en suite and being able to guide whether or not more is necessary. Again, this is not always implemented or even commonly implemented in this context, but it might be worth pursuing given the resources available for most other organs and cancer types. It's also important to note that cytology, by virtue of being fluid-based, can be rapidly converted to flow cytometry if a hematologic malignancy is suspected. It's particularly useful for generating rapid molecular. Given the types of fixatives, they have somewhat different considerations for what can and can't be done compared to formalin. And it can be converted, as I mentioned, to pseudo-histology, which allows for immunohistochemistry phenotyping. So the takeaway message is that I wanted to give in the talk, although I suspect our conversation following will be much more fruitful, is we need enough material to evaluate, but most of the time we get enough to tell you what you absolutely need to know in guiding treatment. We have a lot of techniques available, and it's important in context to evaluate the right one. I would say that in general, talking to a pathologist can help with this. Some are more comfortable with certain techniques than others, and it does raise an opportunity for mutual education and advancement. I just wanted to throw in, as I clearly emphasized, cytology might be valuable. We as a subspecialty field don't use it very often, but it provides an opportunity. So the lesion off to the right is my token. It should be a tumor, or I should say it should be a neoplasm, but it wasn't. This was a lesion that was worked up rather extensively for a primary histiocytosis, and in the end, ended up looking more like a storage disorder in an older individual. We did some additional studies, and in the end confirmed that the most likely diagnosis here was that this was actually a drug toxicity effect, creating a mass-like lesion in the heart. I just thought that was a cool, interesting OMA to end with. We're going to have a conversation following this, but thank you. My email address is there. Please feel free to reach out. Thank you very much.
Thank you very much, Michael. I learned a lot for that. And for a guy who spends a lot of time talking to pathologists with you as well as before you came, I'm happy that I learned a lot from that. Anybody have any questions, please put them into the chat. I'm going to let you know that I'm going to give you a lot more pathology specimens. You can drag them and dip them and tap them as much as you want. I'm going to ask specifically about cytology, though. I always thought cytology was, an aspirate, a needle aspirate. You're saying that we can do that on the table. And what should we do? Take a needle and aspirate some and give it to you as well as the piece of tissue we're taking?
If you want, that is one option. Additionally, solid tissue can be dabbed or smeared on a slide in the frozen section suite and generate cytology. Our suite is not particularly well set up for cytology at this time. The better option right now would be to request an on-site assessment. Our capacity at UHN for doing that unscheduled is not stellar right now. We're understaffed. But scheduled is actually quite straightforward. Patrick actually mentioned he had done several that way, which I assume were also scheduled. And the combination of that with needle core, excisional biopsy, et cetera, can be very powerful in that even if the cytology doesn't tell you what the lesion is, it can at least tell you that it's cellular versus necrosis.
Cellular versus? What did
necrosis.
You say?
So we had that one lesion recently. I don't know if it's the same one Patrick showed or not, but we had a lesion that was 80% necrosis at its core, and it was very likely that the core was going to pull back the necrosis preferentially. One thing to have considered in that, although I suspect Patrick knew this case far better than I, would be to do an aspirate first, figure out where cellular tumor was, and then to pass the core into that same site. Patrick, I don't know if you want to add anything to that.
The tissue we give you is small. I'm just looking at some of the questions that I have. The tissues that we give you are small. I give you big pieces because I'm in there, but the tissues you receive sometimes are very small, be it from something that Patrick gives you, or after a heart transplant, we get to biopsies. And you spoke about the different stains that you can do to help us determine what these are. Once the person has a stain, say an H&E, how much does that section taken out from the rest of your sections? And can you reuse other stains in the same section, given the fact that you have a small amount of tissue? Probably for the molecular stuff, it's a different story because it's different thing. But once you stain it with one stain, how much does that remove from the amount of tissue that you actually have to make a diagnosis?
So from a practical point of view, a single stain takes about 15 to 20 microns of tissue depth. If we cut a number of stains in sequence, that is directly additive with virtually no waste. The real problem comes if the initial panel isn't sufficient. You will then have to spend another 50 to 100, frequently 200 microns in order to get back into the tissue again, at which point you can then continue ordering stains. The local practice, as preferred by our local sarcoma expert, is to not cut stains up front, which had been very popular in lung, how old am I now? 10 years ago, but has evolved because the molecular is so high priority that it's favored that you save the material for that as best as possible. So if a few stains can answer the question, save more for molecular. If you need more stains, cut as few as possible so you have as much as possible for molecular. And Patrick's back.
From a practical point of view, the first step always when we see somebody who has an intracardiac portion of a tumor is to get a percutaneous transvenous biopsy. And I'm asked, and it's asked to us here today, is how many samples, the minimum do you need? You're going to say as many as you can. And what biopsy containers do you need to send the samples in?
Sure. Thanks, Diego. It's a great question, and thank you, RJ. From a practical point of view, in my experience with experienced operators, which I get the benefit of working with frequently, if not all the time, a typical endomyocardial biopsy of around 2 millimeters per piece, typically about 3 pieces is reasonable to work up most tumors. That said, endomyocardial biopsy, for some reason, tends to end up with less material in the end available for molecular. Part of that is I suspect the technique we're currently using in the histology lab, and I'm actually revisiting that. But there's no question that the endomyocardial biopsy, the more the better, but at the same time, it's a tumor, it's going to go badly, et cetera. So I am recommending 3 pieces of around 2 millimeters, which isn't dissimilar from the minimum requirements for transplant. Obviously, the more we get for either of them, the more certain we are.
And what about the containers he sends them in?
Oh, sorry. Yeah. In general, formalin fixed per tumor is the right thing. If you have a suspicion for hematolymphoid, it is worth sending a separate piece for flow cytometry. I will say that EM in tumors is pretty much not favored at this time. And one of the biases in the past was to send a separate piece for molecular, which is actually not valuable. You actually have to look at the H&E for the molecular to be interpreted. One thing to consider is possibly sending them in separate vials. I will say that at our institution, the resource utilization of that is usually avoided because we can take a single piece out of the block if we need to and test just that piece.
Patrick?
Favor formalin.
Yeah, thank you. I just wanted to address the question regarding the FNA first and then determine the area that has necrosis or it has more vital tissue for analysis. Well, that's an approach we're using quite frequently. There's only one caveat. For FNA and then core, you need coaxial technique where you place a larger needle through which you then have to do the core biopsy, unless you navigate twice, which is always possible. So there's a bit of a challenge here because the diameter would be bigger. But even if that's possible, what I have seen, and I wanted to ask you back, if you sample FNA, I have seen not infrequently that there is a bleed, and the bleed deteriorates the core that we can harvest afterwards, unless the tumor is so large that we can re-navigate. Could you comment on this negative impact of FNA first? And the second question is, how many cores do you actually need? You talked about 1 to 2 millimeters for molecular, but would more cores from the same location overcome or mitigate that risk?
Yeah, great question. Thanks, Patrick. On the first one, you're not the first person to mention the bleeding problem to me. And I think, as we've discussed, it's probably much more common in tumors relying on coronary branches for their circulation. They're getting much higher flow, et cetera, not to mention they're around this big chamber of blood thing. So I don't know is the answer. Cytology is so minimally utilized in cardiovascular tumors at all that I think it's a very valid question. Certainly that is described, as you know, in any number of other sites, and is in reality a problem. It is fascinating that it's not a problem on things like thyroid lesions, leading me to believe that visceral lesions are simply more intrinsically challenging in that regard. So it'd be interesting to have enough information. I know that the folks at Methodist are doing a slightly higher volume of cytology. We actually have someone who did her cytopathology fellowship at Methodist and has the advantage of having seen some of these things and can provide us with internal expertise. I will say most centers probably don't have a lot of people that have seen this stuff, but this is the value of training at places that have. I trained at Brigham and Women's. We had seen a lot of it there. Very strong cytology group led by Ed Sivas. But, you know, I'm not sure that UHN would have a robust ability to train you yet. We're working on it. And the how many cores are enough in general, we're going to have to cut into any core you send us. So I'm not sure that sending us more helps. This is one of my ongoing questions that you will hear. For every 3 pathologists that you ask, you'll get 5 answers back. The value of splitting them between blocks or not, I have not found it valuable. I find the exact same limitations between them. And I have a lower threshold for cutting something out of one block and putting it in another. So the upfront resource utilization considerations may be valuable. For any fellows who want to spend some time with us, be they surgical, interventional radiology, or pathology, this is a powerful opportunity for research. Subtle.
Patrick, how many cores do you try to take when you take cores, Patrick?
Well, that's a good question. It really depends on the location. I try typically to take at least 2. I do, as you mentioned, Robert, I take photos. And the reason why I take photos is to ensure that the whole line of processing in the lab is aware of what we harvested, because we have seen at no one's individual fault that when there's necrosis, it kind of dilutes and doesn't go, doesn't reach the pathologist. So I try to take at least 2 if possible, recognizing that the complication rate goes way up the more cores you take, and there's a fine balance between. If I may add only one more question, Michael, and I wanted to hear what you think. What we have done, and again, this is anecdotal and not great experience, but maybe a potential area of research, is what is your thought about touch prep of a core inside once you harvest the core, roll over a slide and use that for cytology? And the second question is, what do you think if we have fragmented material, should we send the formalin to a cytopathologist in an attempt to harvest every cell that kind of came out of the compound and maybe lost in surgical pathology?
2 really great questions. I would say that the touch prep of cores is certainly described in other settings. Given the paucity of data for us, I definitely think it's worth trying. Again, a scheduled rapid assessment would be the way to do that. Touch preps are something very familiar to the cytopathology teams. You would probably just want to warn them in advance. They're not doing an FNA, so it'll be the cytopathologist, not the technologist perhaps, but some of our technologists certainly have done touch preps. In terms of the fragmented specimen, this might be my exception to my answer to Diego. If you send that in saline, saline is a stellar specimen to send for cytology. Sarcomas have a history of not shedding cells in that setting. But if they're fragmenting, you're either dealing with something that's falling apart already, so a variation on the sarcoma, or something that's hematolymphoid or carcinoma or neuroendocrine, where it would be valuable. So I think that might be my exception, where if it's truly falling apart, send it in saline and just make sure it gets to the lab immediately. because that way we can convert whatever to formalin versus cytologic specimen. Most places, cytology and surgical pathology don't go to the same place, including our institution. So make sure you put a thing on there to, contact a pathologist, et cetera. I actually think it would be a valid use of the intraoperative consultation pathologist. I do not perform those right now, so I'm not sure my colleagues would appreciate me saying that. But I do think that tissue triage is an important part that we as a field of pathology could be more engaging in.
I think what you've just said there is very important. What can we do in the operating room to help you give us the best answer possible, both in terms of calling the pathologist before we start, having a discussion with them, having somebody else like a cytopathologist available. I didn't know that until now. And the other question is, in other words, we should book these cases at the beginning of the day instead of the end of the day. What happens if somebody comes to us on the weekend? What should we do about that? When do you call in a pathologist? When's the best, and how do you treat the specimen otherwise? So what can we do to help our patients? Because that's what we're there for. We do the operation, we do the biopsies, but you help us. And if we do it wrong, you're not going to be able to help us.
And I might quietly be frustrated. In general, communication, I think, is the right answer.
Sure.
There's no question you will get an initial response of frustration when you're asking a question that a pathologist might not deem relevant or useful. But you can, I mean, in my case, you can always text me during the day and I can track down someone. Cytopathology actually has a separate on-call number during the day. On call, most centers, the surgical pathologist and cytopathology, are covered by the same on-call person. I will say that our model, and this is probably becoming more common, the purpose of the on-call pathologist is to identify a useful pathologist. So, for example, if it's a hepatocellular carcinoma and you call me in the middle of the night, I'm calling one of the two liver people, but I'm facilitating that for you. So you only have to know one number overnight. That's again a conversation. I know that we at UHN, and I'm sure this is true everywhere else, revisit the nature of what we can do during the day and after hours, on call, on demand, et cetera, as what is the best way to help. And I think that, ironically, I think we do more surgical frozen sections than we need to, and too few of other options, because the conversation has degraded over time. And this is over decades. So I think it would be useful to see what happens if we restart that conversation. But that requires you accepting that when we say no, that might be the best answer.
Yeah, I think that's important. I think a discussion has to happen. And especially in the past, it's different than people's knowledge. As a person like me who's been in practice for almost 30 years is different than the knowledge of the people who are coming in now. And unfortunately, people who are coming in now have old teachers like us, and we need to bring the pathologists into the operating room to help us to understand, and into the biopsy specimen. It's very, very important, very valuable lesson for us all. Thank you very much for that.
No problem. Thanks for giving me the chance.